morning, students. Myself, Dr. Abhishek Raj from Department of Pharmacology. Today, we will study about Class 1 and Class 2 anti-arrhythmic drugs. First, the classification. Vaughan Williams classification of anti-arrhythmic drugs. Under this classification, there are total 5 classes: Class 1, Class 2, Class 3, Class 4 and Class 5. Class 5 includes miscellaneous drugs. So Class 1 is sodium channel blocker, Class 2 beta blocker, Class 3 potassium channel blocker, Class 4 calcium channel blocker, and Class 5 miscellaneous includes dioxin, magnesium sulfate, adenosine and atropine. This is about Vaughan Williams classification of anti-arrhythmic drugs. Now, before studying sodium channel blocker, we will first see important details about sodium channel. So, sodium channel exists in 3 states: open state, inactive state and closed state. In open state, sodium enters in myocardial cell in open state. You can see in the diagram. Here, sodium is entering into the myocardial cell in open state because the sodium channels are open. So this is open state of sodium channel. Next is inactive state. Here sodium cannot enter in myocardial cell in inactive state. So here I have put a cross here because in inactive state sodium cannot enter. Then in closed state sodium cannot enter in myocardial cell in closed state. So sodium cannot enter at all in closed state. Now, after open state, there will be inactive state, and after inactive state, there will be closed state. After closed state, what will happen? There will be again open state. Because after closed state, impulse causes opening of sodium channel. So open state comes after closed state. But after inactive state, after this inactive state, I put a cross mark here because after inactive state, open state cannot come. After inactive state, open state cannot come back. So after inactive state, impulse cannot cause opening of sodium channel. So impulse cannot cause opening of sodium channel after inactive state. That means sodium channel is refractory to impulse. So that time period is known as effective refractory period. And I have shown in the action potential of ventricular cell, this action potential duration is equivalent to effective refractory period. So if action potential duration is prolonged, effective refractory period is prolonged, and we can say that sodium channels are inactive state for long period. Now we will first see Class 1 anti-arrhythmic drugs, and Class 1 anti-arrhythmic drugs include sodium channel blocker. And this Class 1 anti-arrhythmic drugs are further classified into 1A, 1B and 1C based on their action on potassium channel. So, sodium channel blockers. In this slide I have covered all the 3 class 1A, 1B and 1C important features. So, one characteristic of sodium channel blocker is they decrease the rate of depolarization So they decrease the slope of phase 0 of ventricular action potential. Now class 1 is further classified into 1A, 1B and 1C based on the action on potassium channel. So in class 1A, what are the features? They are sodium channel blocker, moderate. Not mild, not strong, they are moderate sodium channel blocker. So there will be decrease in rate of depolarization and there will be decrease in slope of phase 0. At the same time, there are also potassium channel blocker. So there will be decrease in rate of repolarization and there will be increase in action potential duration. So increase in QT interval on ECG and increase risk of torsade D points. So here I can say what is QT interval? We have already studied about QT interval in our previous lecture. That is it is equivalent to action potential duration, but QT interval is from the start of ventricular depolarization to the end of ventricular repolarization. From the start of ventricular depolarization to the end of ventricular depolarization is QT interval, and it is equivalent to action potential duration. So we know that since sodium channel is blocked, that's why here the rate of depolarization is decreased. So you can I have put a small arrow here. This shows decrease in the slope of phase 0. This is phase 0. This one is phase 0, and there is decrease in the slope of phase 0. Okay, because sodium channel are blocked and there is moderate blockage of sodium channel. Now here potassium channel blockers. So potassium channels are blocked. So rate of repolarization is decreased. You can see here rate of repolarization. Rate of repolarization is decreased. So rate of repolarization is decreased. So this is action potential duration. Action potential duration is prolonged. That means QT interval on ECG is prolonged. That is increased risk of torsade D points. Now in 1A, sodium channel, they are sodium channel blocker in open state of sodium channel. Other characteristic of 1A are they have anticholinergic effect. So they will stimulate AV node. As a result, PR interval on ECG will be short. And they have wide QRS complex. 1A on ECG, they have wide QRS complex. QRS wave on ECG is due to ventricular depolarization. Now class 1B. In class 1B, what are the features? There will be sodium channel blocker. It will be sodium, they are sodium channel blocker and the blocking is mild. So they are mild sodium channel blocker that result in mild decrease in rate of depolarization, that result in mild decrease in slope of phase 0. At the same time, they are potassium channel opener that result in increased rate of repolarization. So action potential duration decreases, QT interval decreases, and no risk of torsade D points. So as shown in this diagram, you can see here the depolarization rate is decreased but is very mild. So this slope of phase 0, there is mild decrease in slope of phase 0, very mild decrease in slope of phase 0 as shown in the graph. Since they are potassium channel opener, so what will happen? That will increase the rate of repolarization. Increase the rate of repolarization. So here is the graph. The red one is the graph of 1B. Here the red one is the graph of 1A. And the black one is normal action potential, ventricular action potential. Here the red one is the graph of 1B. So what will happen? Increase in rate of repolarization because of opening of potassium channel. What will result? Shortening of action potential duration. That means QT interval on ECG will be short. So no risk of torsade points in case of class 1B. In class 1B, they are sodium channel blocker in inactive state. So they are sodium channel blocker in inactive state. So there will be decrease in effective refractory period. There will be decrease in effective refractory period. Other features of 1B class, they have no effect on AV conduction, atrioventricular conduction, they have no effect. So no effect on PR interval on ECG. Also, they don't have any effect on QRS complex on ECG. No effect of class 1B. So class 1C, these drugs are strongest sodium channel blocker, or we can say that they are most potent sodium channel blocker. So decrease in rate of depolarization will be maximum, and decrease in slope of phase 0 will be maximum. You can see here, the decrease is maximum. This decrease is maximum. Decrease in slope of phase 0 is maximum. Decrease in rate of depolarization is maximum. Decrease is maximum. At the same time, on potassium channel, there is no effect. So there is no effect on rate of repolarization. As a result, no effect on action potential duration, and we can say that no effect on QT interval. Other features of class 1C, they are sodium channel blocker in open state. They are AV node block. There will be AV node block. So class 1C result in AV node block. So conduction through AV node decreases. That result in long PR interval on ECG, and PR is the interval between atrial depolarization and ventricular depolarization. Other features on ECG, in class 1A, there will be wide QRS. In class 1B, no effect on QRS. And class 1C, there will be wide QRS. These are the important features of class 1A, 1B and 1C. Here in this ECG, here I have so small ECG. I have small ECG here. I have shown the PR interval. PR interval I have shown. So just remember this line is PR interval. That is time between atrial depolarization and ventricular depolarization. So PR interval corresponds to pause in AV node. Now we will study the drugs in sodium channel blocker. So again the characteristic I have written, sodium channel blocker, decrease in rate of depolarization, that result in decrease in slope of phase 0. So class 1 is further divided to 1A, 1B and 1C. Here you can see there is action potential duration prolonged, there is shortening of action potential duration, and here action potential duration no effect. So 1A drugs include quinidine, procainamide and disopyramide. 1B drug include lidocaine, mesalazine, phenytoin, tocainide. And class 1C drug include incanide, flecainide, propafenone and morphine. Now class 1A drugs include quinidine, procainamide and disopyramide. Now let's study about class 1A drugs in detail. So what are the use of class 1A antiarrhythmic drugs? So they are used for atrial and ventricular arrhythmia. Now the first drug under class 1A is quinidine. So what are the most common side effects of quinidine? Nausea, vomiting and diarrhea are the most frequently seen side effect of quinidine. Due to alpha blocking, there is a side effect, that is hypotension, seen with quinidine. And quinidine has anticholinergic side effect like dry mouth, midrasis urinary retention. And quinidine, since it is class 1A, so there is an increased risk of torsade D points. Now quinidine, it is a dextroisomer of quinine obtained from cinchona plant. In overdose, it can cause synchronism, which is characterized by vertigo, tinnitus, headache, deafness, and blurring of vision. Due to many side effects, quinidine is rarely used. Now we will study what is the effect of parasympathetic nervous system, that is vagus nerve, on heart rate. So vagus nerve, that is parasympathetic nervous system, they stimulate M2 receptor. You can see vagus nerve, that is parasympathetic nervous system, I put a plus mark here, that means they are stimulating the M2 receptor in AV node. And this M2 receptor in AV node is G inhibitory. It is G inhibitory. So what will happen? There will be, since it is G inhibitory, so upon stimulation, there will be decrease in AV conduction and decrease in heart rate. So this is happening because of vagus nerve or parasympathetic nervous system. Now if we give a drug known as quinidine, which has anticholinergic property, and this quinidine is given in case of atrial fibrillation. So in case of atrial fibrillation, if we give quinidine, in patient of atrial fibrillation, if quinidine drug is given, it will block the M2 receptor. It will block the M2 receptor in AV node. So since this M2 receptor is blocked, that means G inhibitory is blocked. So G inhibitory is blocked, that means AV conduction will be increased, and that result in increase in heart rate, and that is known as paradoxical tachycardia. And this paradoxical tachycardia is seen in case of atrial fibrillation. So normally what happens? Quinidine is anticholinergic drug, and it is given to decrease the heart rate. But in atrial fibrillation, it increases heart rate, and this is called paradoxical tachycardia. So what is the reason of paradoxical tachycardia? Due to anticholinergic activity. Now in atrial fibrillation, there is paradoxical tachycardia caused by quinidine. Now in atrial fibrillation, one more point I want to emphasize. In atrial fibrillation, there is increase in atrial rate. So if we give quinidine, that is sodium channel blocker, in SA node, what will happen? Atrial rate will decrease. So quinidine will decrease atrial rate in case of atrial fibrillation. Other drug apart from quinidine, the use of class 1A is atrial and ventricular arrhythmia. So the other drug under class 1A is procainamide. So by intravenous route, procainamide is given, and that can be used in emergency. Procainamide is metabolized by acetylation, and in long-term therapy of procainamide can result in SLE, systemic lupus erythematosus. Procainamide has less anticholinergic side effect and less alpha blocking. Less anticholinergic side effect and less alpha blocking. So less alpha blocking result in less hypotension. Now what is the use of procainamide? It is used in WPW syndrome, that is Wolff-Parkinson-White syndrome. This drug is used, procainamide, in WPW syndrome. So in WPW syndrome, Let's study the treatment of WPW syndrome. So for acute treatment, we give procainamide or amiodarone. In acute treatment of WPW syndrome, Wolff-Parkinson-White syndrome. But in definitive treatment, radiofrequency ablation of the accessory pathway is done. Radiofrequency ablation of accessory pathway. Now, what happens in Wolff-Parkinson-White syndrome? So, Wolff-Parkinson-White syndrome or WPW syndrome, it is a type of atrioventricular reentrant tachycardia. Reentrant means electrical signal that loops back on itself. So what is happening normally? From SA node, impulses going to atria, and that is causing contraction of both the atria. Then impulse goes to AV node, then ventricle, then Purkinje fibers that contract both the ventricles. Now, from the ventricle to the atria, there is an accessory pathway, and that accessory pathway in Wolff-Parkinson-White syndrome, it is known as bundle of Kent. So what will happen when impulse from SA node, atria, AV node, ventricle, Purkinje fiber reach to the ventricles and causes contraction of both the ventricles? The impulse reaches to atria by this bundle of Kent, and that causes atria to contract before SA node sends out signal. So atria contracts before SA node sends out signal. So I put a cross mark between SA node and atria, because before SA node sends out signal, there will be contraction of the atria. After that, the signal from the atria will go to AV node, then ventricle, then Purkinje fibers to contract both the ventricles. Again, back to the accessory pathway, and this cycle repeats. So what will be the result? Atrioventricular reentrant tachycardia will be the result, in which the heart rate is 200 to 300 beats per minute. So now, for this Wolff-Parkinson-White syndrome, if we will give the drug procainamide, that is class 1A drug, procainamide. So procainamide or amiodarone, what procainamide or amiodarone will do? Procainamide comes under class 1A drug. So procainamide or amiodarone, it will increase the refractoriness of accessory pathway, that is bundle of Kent. So the refractoriness is increased of the bundle of Kent. So impulse will not pass through this accessory pathway. And impulse will pass through the AV node instead. So that is the acute treatment of Wolff-Parkinson-White syndrome. We have increased the refractoriness of bundle of Kent accessory pathway by giving drug like procainamide or amiodarone. So again, the class 1A use atrial and ventricular arrhythmia. The third drug under class 1A, disopyramide. Now this disopyramide has maximum anticholinergic activity. What are the features of anticholinergic activity? Dry mouth, mydriasis, urinary retention. So it is rarely used. Because of this maximum anticholinergic activity, disopyramide is rarely used. Because of this anticholinergic activity, it is contraindicated in glaucoma and benign prostatic hyperplasia. In both the condition, disopyramide is contraindicated. Now it decreases heart rate. This drug decreases heart rate, so contraindicated in congestive heart failure patient. Now we'll see class 1B drug. So drugs which comes under class 1B are lidocaine, phenytoin, mesalazine and tokenide. Now in class 1B, lidocaine. So lidocaine is drug of choice for ventricular arrhythmia only, but is not used in atrial arrhythmia. This is very important. So for ventricular arrhythmia, it is drug of choice, but it is not used in atrial arrhythmia. What is the reason behind this? We know that ventricular cell has long action potential duration. That means long effective refractory period, because we have already studied action potential duration is equivalent to effective refractory period. So a ventricular cell has long action potential duration. That means ventricular cell has long effective refractory period. So long effective refractory period means sodium channels are in inactivated state for prolonged period. Sodium channel in inactivated state for long period. So binding of lidocaine is more, because lidocaine has more affinity for inactivated state than open state. So since the sodium channels are in inactivated state, binding with lidocaine is more. So there will be more blockade of sodium channel, and more blockade of sodium channel will result this drug lidocaine to be more useful in ventricular arrhythmia. Now, so that we see that lidocaine is used only in case of ventricular arrhythmia. It is drug of choice. Now, atrial cell has short action potential duration. That means short effective refractory period. So short effective refractory period, that means sodium channel is in inactivated state for less period. That means binding with lidocaine is less. So less blockade of sodium channel. So not useful in atrial arrhythmia. So we have to remember one point. Lidocaine has more affinity for inactivated sodium channel than open sodium channel. Now in post-MI, post myocardial infarction patient, there is partially damaged or partially depolarized tissue. So there is increase in action potential duration. Due to partially depolarized tissue of heart, there will be increase in action potential duration that result in increase in effective refractory period. So sodium channel is in inactivated state for prolonged period. So if the effective refractory period is increased, that means sodium channel is in inactivated state for long period. Again, if sodium channel are in inactivated state, that means binding with lidocaine is more. So more blockade of sodium channel. That means this drug is very effective in post-MI ventricular tachycardia or ventricular fibrillation. Now, lidocaine. What is the side effect of lidocaine? Lidocaine side effect main is neurological side effect. For example, paresthesia, numbness, delirium and seizure. Now, lidocaine has increased very high first pass metabolism. That's why it is given only intravenously, and is drug of choice for digoxin-induced ventricular tachycardia or ventricular fibrillation, or post myocardial infarction, ventricular tachycardia or ventricular fibrillation. It is drug of choice, lidocaine. So, digoxin-induced ventricular tachycardia or ventricular fibrillation and post MI, VT or VF, this drug is given as a drug of choice. An alternative drug for post MI, ventricular tachycardia or ventricular fibrillation, or alternative drug for digoxin-induced ventricular tachycardia or ventricular fibrillation is phenytoin. And phenytoin also comes under class 1B antiarrhythmic drug. The third drug is mesalazine. Now this mesalazine is oral derivative of lidocaine. And what are the uses of mesalazine? Ventricular tachycardia and diabetic neuropathy. Now the fourth drug under class 1B is tokenide. It is not used because of risk of side effect like agranulocytosis. 1C drugs are incanite, flecainide, propafenone, morisipine. Now class 1C. The important characteristic of class 1C drugs, they are strongest sodium channel blocker, most potent sodium channel blocker, or we can say strongest sodium channel blocker. So used only in resistant arrhythmia, resistant atrial arrhythmia or resistant ventricular arrhythmia, they are used only in that case. One more thing, they are most arrhythmogenic. Since they are class 1C drugs are most arrhythmogenic, so if given in myocardial infarction patient, that can cause sudden cardiac death in case of myocardial infarction patient, because class 1C drugs are most arrhythmogenic. So what are the drugs under class 1C? Incanite, flecainide, propafenone and morisipine. Morisipine is rarely used, and propafenone has additional beta blocking activity that result in bronchoconstriction. So propafenone is contraindicated in bronchial asthma. Now class 2, that is beta blocker. So we will study class 2 anti-arrhythmic drug, that is beta blockers. So class 2 beta blocker. So first we will see how beta blocker is affecting the pacemaker cell, that is cell of SA node and AV node. Before that, we will see what is happening normally. So here I have made the cell of SA node or cell of AV node. Here is beta 1 adrenergic receptor, which is 7-pass receptor or serpentine receptor. And here I have shown the calcium channel on the cell of SA node and AV node. So what happens when epinephrine or norepinephrine binds with beta 1 adrenergic receptor? There is stimulation of G stimulatory protein that is made up of alpha stimulatory, beta stimulatory and gamma stimulatory. So that will result in increase in cyclic AMP, and that will result in increase in protein kinase A. So the calcium channels present on the cell will get phosphorylated, and that will result in calcium influx inside the cell. And this calcium influx is happening in phase 4 of SA node potential. And this calcium influx will result in SA node potential that is responsible for slope of phase 4. So increase impulse generation from SA node and increase in heart rate. So I can show in the SA node potential, the one shown in black color is the normal SA node potential. And this is phase 4. This one is phase 4 and it is due to calcium influx. Now this calcium influx in phase 4 is also causing conduction through AV node. And this conduction through AV node will result in impulse passing from atria to ventricle, and that represents as PR interval on ECG. Now we will see the effect of beta blocker on this cells of SA node and AV node. So beta blocker will inhibit the binding of epinephrine or norepinephrine with beta 1 adrenergic receptor. So G stimulatory will get inhibited, cyclic AMP will get decrease in protein kinase A, decrease phosphorylation of calcium channel, decrease calcium influx inside the cell, and in SA node potential it is happening in phase 4. So decrease calcium influx in phase 4 will result in decrease in SA node potential, so decrease slope of phase 4, decrease impulse generation from SA node, so decrease heart rate, that is negative chronotropy. So this beta blocker is causing negative chronotropy, that is beta blocker is causing decrease in heart rate. Now in this SA node potential, the one shown in black color is the normal SA node potential, and the one shown in red color, it is SA node potential due to effect of beta blocker. So here is the phase 4. You can see there is decrease in the slope of phase 4. In this graph of SA node potential, we can see there is decrease in the slope of phase 4 happening due to decreased calcium influx in phase 4. Now, this decreased calcium influx in phase 4 is also decreasing the conduction through AV node. So, impulse will pass from atria to ventricle slowly. That will result in prolongation of PR interval on ECG. And what is PR interval? It is a time between onset of atrial depolarization to onset of ventricular depolarization. From here till here, it is the PR interval. From the onset of atrial depolarization to the onset of ventricular depolarization. So, beta blocker is decreasing the conduction. So, beta blocker has negative drone-tropy action on pacemaker cell. So, how beta blocker is having negative chronotropy and how beta blocker is having negative drone-tropy can be explained with the help of this diagram. Now, the effect of beta blocker on the effect of beta blocker at non-pacemaker cell. So, non-pacemaker cell, for example, cells of atria and ventricle. First, we will see what is happening normally. Epinephrine or norepinephrine binds with beta-1 adrenergic receptor, which is G-stimulatory. So, increase in cyclic AMP, increase in protein kinase A, increased phosphorylation of calcium channel. So, increased calcium influx happening in the cell of atria and ventricle. In axial potential duration, this calcium influx is happening in phase 2. This is phase 2. In action potential of atrial cell and ventricular cell, this is phase 2, and this phase 2 is due to calcium influx. So this calcium influx is responsible when calcium enters inside the cell of atria and ventricle, then calcium enters into the sarcoplasmic reticulum. And during action potential, this calcium gets released from the sarcoplasmic reticulum. It acts on actin-myosin complex inside the cell, and that results in myocardial cell contraction. And the property of this myocardial cell contraction is known as inotropy. Now we will see the effect of beta blocker on these cells of atria and ventricle. So beta blocker will inhibit the binding of epinephrine or norepinephrine with beta-1 adrenergic receptor. So G-stimulatory protein will be inhibited, cyclic AMP will get decreased, protein kinase A will get decreased, phosphorylation of calcium channel will get decreased, decreased calcium influx in phase 2, so decreased calcium entry inside the sarcoplasmic reticulum. So when the action potential comes, the release of calcium from the sarcoplasmic reticulum will get decreased. So decreased action on actin-myosin complex. So decreased myocardial cell contraction, that is known as negative inotropy. So beta blocker is also having negative inotropic action. Now beta blocker should not be given with verapamil. Beta blocker should not be given with calcium channel blocker like verapamil. Now let's see the cell of acido-nodal AV node and the effect of beta blocker and verapamil on the cell of acido-nodal AV node. So here we have beta-1 adrenergic receptor, which is a type of 7-pass receptor or serpentine receptor. Now you can see epinephrine or norepinephrine is binding with the beta-1 adrenergic receptor. Now when we give beta blocker will inhibit the binding of epinephrine or norepinephrine with beta-1 adrenergic receptor. As a result, calcium influx through the calcium channel will get decreased. At the same time, verapamil, if given along, will inhibit the calcium channel directly and will also result in decrease in calcium influx. So because of the added effect, calcium influx in phase 4 will decrease too much, and that will result in too much decrease of acido node potential. So impulse generation from acido node will decrease a lot and heart rate will decrease much more. That will result in severe bradycardia and sometimes asystole, that is heart ceases to beat. This too much decrease in calcium influx in phase 4 will also decrease the conduction through AV node much more. And this added effect, the conduction through AV node will be decreased so much that it can lead to AV block. that is, impulse from atria will not reach to the ventricle. This is the reason why beta blocker should not be given with calcium channel blocker like verapamil. Next lecture, we will study further about antiarrhythmic drugs. Thank you.